Hey everyone. So today let's talk about more about afterload. Okay. In the other video we talked a lot about preload, what increases it, what decreases it, what is it, and how it changes the cardiac output. Okay. So preload was basically the amount of blood that was in your ventricles at the end of diastole. What's afterload and why is it important? Afterload, whenever you think of afterload or whenever you see it, just think of how difficult uh, is it for the ventricle to send blood out into the aorta, okay? That's really what it is. And there are a lot of different definitions for it. You'll see like all these different ways of it being described, but really this is the most easy way to understand it and really the best way to understand it because the way they ask you questions on the USMLE, this is how you have to understand it. How difficult is it for the ventricle to send blood out? Okay, so if you have increased afterload, it's more difficult. If it's decreased afterload, it's easier to send blood out. Okay, and I'll be more specific now. It's really dependent on a couple things. One of the biggest things is total peripheral resistance. What does that mean? That means when you have your, big arteries that branch off into different, little arterioles, etc. Um, okay. What this means is that in these arterioles, what's the resistance going on over here? Is there a lot of resistance or low resistance? Why? Okay, because when you have your ventricle here, and this is my aorta. I'm sending blood through here, right? Goes to the aorta, goes into my other arteries here, right? Now, what this is sensing is how basically narrow are these arteries. If they're really narrow, would it be harder or easier to send blood through them? If they're narrow, it would be harder, right? More difficult to send blood through. Now, if they were dilated and their radius was um, bigger, would it be easier or harder? It would be easier to send blood through, right? Because you have a lot more room to send blood. Now, I'll make this a little more simple, right? Because of that law that we have, I think it's Laplace's law, where uh, where we use resistance in there. Okay, resistance is equal to 1 over radius to make it simple. Okay, this is a very, very important formula to know, okay? A lot of different concepts are really explained from this. Resistance is equal to 1 over radius. So what does this mean? As my radius increases, what am I doing to the resistance? Well, I mean, don't even look at it mathematically. Let's take a look at two arteries. One artery here that's 5 centimeters, and another artery here that's 10 centimeters, okay? Which one do you think it's easier to send blood through, the 5 centimeter or the 10 centimeter? This one, right? Why? Is because it has a bigger radius, a lot more room to send blood through, okay? Now, let's look at it mathematically. If we're increasing the denominator, the lower number, what am I doing to the overall number? I'm decreasing it, right? So what does this mean? That as my radius increases, as I went from 5 centimeters to 10, what did I do to the resistance? The resistance decreased. Makes sense? As you decrease the radius when you go from 10 to 5, what did you do to resistance? You increase the resistance, right? Because if you look at one big aorta here, right, and it branches off to different um, other arteries, okay, the size of these arteries is what depends or what makes up the afterload, okay? If these arteries, arterioles, actually, this is a very, very important point. In your entire arterial tree, the aorta, the arteries, the arterioles, the capillaries, the venules, all that, which ones are the ones that actually do the vasodilation and vasoconstriction? It's the arterioles. Okay, that's actually a USMLE question. Why is it the arterioles? Because they're the ones that actually have the smooth muscle. Okay, and they have the smooth muscle that allows them to constrict. So if they have the smooth muscle, they have the alpha 1 receptors on them that actually are able to constrict. And when they constrict, what am I doing to my radius? I am decreasing the radius, right? Does that make sense? And if I decrease the radius, what am I doing to resistance? I'm increasing resistance. So whenever you vasoconstrict, you increase resistance. When you vasodilate, you decrease resistance. Okay, makes sense? In other words, and correlating now with afterload, afterload is really directly related to resistance. The more resistance I have, the increased afterload. Meaning, it's more difficult to send blood from the aorta, from the ventricle into the aorta, right? Because of all the resistance here. There's so much resistance that it's really difficult. It's hard to get through. And if it's hard to get through, the ventricle has to work harder. Okay? This is a big point here. The ventricle has to work harder to send the same amount of blood out. Okay? Now let's take a look now what I mean by that. Okay. So, if I have my ventricle here, I'm just going to draw it very simply. Okay, and if I have my aorta coming out through here, okay, simple picture. Aorta, this is my left ventricle, right? Let's say I have 10 cc's of blood in here, right? And usually I send out 5 cc's of blood into the aorta, right? And again, we have our typical blood vessels here, right? Okay, all of our blood vessels here. 1, 2, 3, 4. Okay, each one of these blood vessels has a specific resistance. Okay, and a specific radius. Okay, let's say each one of them has a 5 centimeter radius. Just to be simple here. Be very simple, just to explain and help you understand what I mean by this. This isn't real, like in real life. This is not how it really is. But just to help, be simple, okay? So I have 10 cc's, which is my end diastolic volume. I send out 5 cc's, which is my stroke volume, and that 5 cc's goes in different directions here into the different arteries, right? Okay. Now, my ventricle here, my myocardium, the heart muscle, worked a certain amount. It put in a certain amount of strength to contract in order to send out the 5 cc's of blood and send it all through here into these arterioles. Now, let's take a look at another picture now. Let's say the radius changes here. Okay, let's say it's not 5 centimeters anymore. Let's say it's 2 centimeters. 2 centimeters, everywhere it's 2 centimeters, okay? Okay, they're a lot more narrow. They're more narrow, okay? The arteries are more narrow. So what did I do? I decreased the radius, and if I decrease radius, what did I do to resistance? I increased the resistance, right? Now, let's see now. I had 10 cc's here again. And I have to send out 5 cc's, right? Because I have to maintain my ejection fraction. I have to send out a certain amount of blood. This 5 cc's now, will it be harder for it to go through here or easier to go through here when I only have 2 centimeters in each artery? It would be more difficult. Makes sense? Because it's more narrow. It's not easy for blood to get through. So now, in order to get that 5 cc's out and into these arterioles, my myocardium here, my heart, has to work even harder to send it out because it's meeting so much resistance. What did I do? I increased the afterload. by decreasing the radius and by increasing the resistance. I increase the afterload, and since I increase the afterload, it's really difficult for the ventricle to send the blood out. So it works really hard, really hard to send it. So it contracts a lot stronger now to send the same amount of blood out. If it's contracting stronger, it has more contractility. And if it has higher contractility and it's contracting harder, it's a muscle, right? If I went to the gym every day and I lifted a 20-pound dumbbell every day, what would happen to my bicep? It would hypertrophy, right? Why? Is because my muscle is sensing that, hey, you know what? My bicep needs to be strong in order to be able to lift this 20-pound dumbbell every day. It's getting used to it. So it hypertrophies. It gets bigger. Now remember, muscle cells do not replicate. They don't increase in number. They just increase in size, which is hypertrophy, right? Well, the myocardium does the same exact thing. It's working a lot harder now to send that 10 cc's of blood out. So what's happening to the myocardium? The myocardium is now hypertrophying. It's getting bigger, it's getting stronger, just like a bicep would, okay? In order to pump the blood out, it has to be stronger. Now, let's take a look at a correlation here. Well, you find left ventricular hypertrophy, they always call it LVH, right? Left ventricular hypertrophy in a lot of people. Why? Why do they have hypertrophy? Well, because of hypertension. Why does that make sense? How does that make sense? Is because people have atherosclerosis, especially elderly people, people who have a lot of the high cholesterol, and they have a lot of atherosclerosis going on in their arteries, which narrows them, which hardens them and thickens them. Okay, which causes hypertension, a high blood pressure. Now, what do I mean by that? If they have high blood pressure here, hypertension, I have a really high pressure. And when I have a high pressure here, what do the arteries want to do? They want to constrict. Okay? Whenever there's higher pressure, they have a tendency to want to contract back. Just like the ventricle does when it's stretched out and wants to contract back, the same thing. The arterioles want to do the same thing. Also, because of atherosclerosis and the foam cells, there's a lot of thickening of the arterial walls, okay, which makes them less compliant. So I have really high pressure here, really high pressure. Now let me ask you a question. If there's really high pressure up here and down here, would it be easier or harder for this 5 cc's of blood to get through? It would be more difficult. A lot more difficult. So that's why hypertension would make it more difficult. Hypertension is equal to increased afterload. Okay? Hypertension causes more afterload. So if it causes more afterload, the ventricle works harder. The ventricle works harder, it hypertrophies. That's why you always see LVH in people with hypertension, okay? It's always a board question. They always ask this on the usmle. Well, that's the reason why, okay? Because the muscle's working harder. All right, makes sense? Okay. Now, let's take basically an example now. Let's take a look at a patient who just suffered a myocardial infarction. And we're going to take a look at the same ventricle, the left ventricle. Let's say they infarcted some part of their ventricle here, right? Okay, and simple drawing, aorta's coming out, right? Okay, and the blood is going through. Okay, this is the aortic valve, etc. And this is my left ventricle, right? Let's say they just had a myocardial infarction. if they had an MI or if they're suffering angina, basically ischemia, to my myocardial tissue here, and my heart muscle doesn't have enough oxygen to deliver to all the different tissues here. Do I want my ventricle working harder or not that hard? I don't want it working harder. Why? Is because I want to conserve the oxygen. I don't want the ventricle, this myocardium using up all the oxygen and none getting to the ischemic area. I want to relax the ventricle. I don't want it working that hard. Well, we talked about one way we can do that by decreasing preload. We gave nitroglycerin for that, right? What did it do? It venodilated, and it venodilated decreased venous return. So if you decrease venous return, we decrease preload, and if we decrease preload, the amount of blood in the ventricle decreased, and if that decreased, it wasn't stretching it, and if it's not stretching it, it won't contract as strong. Okay, makes sense? Well, in a patient with angina or an MI, we can do another thing. We can decrease the afterload. Right? Why do we want to do that? We don't want to make it difficult for the ventricle to contract. Make sense? We want to make it easier so it's not extracting that much oxygen. How do we decrease afterload? Well, what did we say it was dependent on? The total peripheral resistance, right? Which are my arterioles. Smooth muscle. And what receptor? Alpha 1, right? So all I need to do is decrease my total peripheral resistance. How do I decrease resistance? I have to increase the radius, right? Remember? I have to increase the radius. How do I do that? By, hypothetically, all you have to do is just dilate the arterioles. If I dilate the arterioles and make the arterioles really big, the blood will go very easily through here, and the ventricle will not have to work that hard to send it through. So let's dilate. Alpha 1 antagonists, right? This is just hypothetical. Okay, so if they gave you a question on the USMLE and they said a 55-year-old male with hypercholesterolemia, um, diabetes, hypertension, came in with chest pain, and they talked about Afterload for another 2 lines and asked you which of the following drugs would help decrease Afterload or would help, basically help this patient. And you look at a bunch of drug names. All you have to think of at that time is think which of these causes vasodilation in my arterioles. Which of these will increase my radius? Same thing. Which of these will decrease my resistance? Okay, an alpha 1 antagonist makes sense, right? Like what? Tamsulosin. Usually used for BPH, right? You never see it being used for MI, right? And in an emergency department, you never see, patient's having an MI, let's give him tamsulosin. No, that never happens. But for the USMLE, you have to be able to think hypothetically, okay? Don't think of, tamsulosin, I never used it in the emergency department, I never saw it being used. No, don't think of it like that. These questions are about mechanisms. They want to know if you know what's the mechanism of action of tamsulosin. It's an alpha 1 antagonist, usually used for BPH, etc. But it would make sense, right? Because if I vasodilated my arterioles, it would increase my radius and decrease the resistance. Okay, just hypothetical. But what else do we give to patients who are having an MI or ischemia? ACE inhibitors, right? What do? They block the production of angiotensin II. What does that do? What does angiotensin II normally do? It vasoconstricts. So if I decrease angiotensin II, I'm actually vasodilating, which would help decrease the afterload and help in MIs, right? Okay, makes sense? Okay, now let's take a look at some things again that increase afterload. We said hypertension, right? And that's really due to atherosclerosis. Okay. What's another thing that does it? A hand grip, right? Why does strong hand grip, well, and what I mean by hand grip, I mean contracting your hands, making a fist for a really long time, okay, and contracting really hard. Why? Is because, again, the muscles will, push on the arterioles and actually cause the arterioles to actually, be more narrow, making higher pressure there. And the more pressure there is there, the more difficult it is to send blood through, okay? So hand grip, again, increases afterload. Okay. What else does it? Aortic stenosis. Does that make sense? Okay. Let's take a look at my ventricle again and my aorta coming out, right? This is my aortic valve. Okay. And it usually opens up, sends blood through. Now, let's say it's really, really stenotic and closed. Okay. It's really stenotic. If it's like that, would it be easier to send blood through or harder? More difficult, right? Why? Because I decrease the radius. And since I decrease the radius, I increase the resistance. So anytime you have aortic stenosis, think increased afterload. Same thing, okay? It'll be really, really difficult to send blood through. Now, if I have increased afterload and aortic stenosis, what would happen to my ventricle over time? Connecting the dots here, guys. What would happen? I would get LVH, left ventricular hypertrophy, right? Does that make sense? So now I would get it in hypertension. For long-standing hypertension, I'm going to get hypertrophy. In aortic stenosis, I'll get hypertrophy also. Why? It's because my ventricle has to work really hard to send out the same amount of blood. Make sense? Okay. Now, let's say they give you a pharmacological question and they ask you, oh, which of the following drugs causes increased afterload? All you have to think of is, well, what do these drugs need to do? They need to constrict the arterioles to increase my total peripheral resistance. So, what drug constricts arterioles? Which is an alpha 1 agonist. One example is phenylephrine, right? Okay, does that make sense? Phenylephrine is an alpha 1 agonist, right? Okay, all right. Again, guys, if you have any questions or if something's not clear, feel free to comment and I'll do my best to answer the questions, okay? Thanks.